Welcome to the EAU podcasts. In this episode, UROONCO Prostate Cancer Associate Editor Dr. Rajwa talks to Professor Zilli on local therapy in metastatic prostate cancer.
Welcome everyone to the UROONCO EAU podcast. My name is Pawel Rajwa, and it's great honor for me to have today Professor Zilli. Welcome, Professor Zilli.
Hello, thank you so much for this kind of invitation. So I would like to introduce myself. So I'm Thomas Zilli. I'm a radiation oncologist. I have the department in the Oncology Institute of Southern Switzerland in Bellinzona. My focus is mainly on prostate cancer, but I'm also treating all the GU tumors.
Thank you very much. Today we'll talk about local therapy in metastatic prostate cancer. And my first question to you is, who are the patients we should still consider for prostate radiation therapy in the novel metastatic hormone-sensitive prostate cancer?
That's a good question. So because all the trials that we have at this time, we have three main trials that explore the role of treatment to the primary with radiation. So namely HORAD, STAMPEDE, and PEACE-1. All these three trials were based on conventional imaging. So it means using bone scan and CT scan. This patient included de novo metastatic disease, and then they were stratified based on the volume. In specific, STAMPEDE had a pre-planned analysis looking at the volume of the disease, low versus high volume disease based on the charting criteria. The question now is that we are using more and more for initial stage in PSMA PET-CT, so we have a shift in the diagnosis of more patients having a true oligometastatic disease, or some patients that were considered before has a low volume. In reality, they have a little bit more disease sites on the PSMA PET-CT. So this makes things a little bit challenging sometimes. But I think that for recommending a treatment to the primary, we are staying more on the use of conventional imaging. But of course, you can discuss in a multidisciplinary team if for selected cases having more than 4 lesions, bone lesions on PSMA PET-CT, if you can include and consider, even in these cases, of the treatment to the primary.
And from your perspective, which is more important for you, PSMA PET or conventional imaging results? On which you make more your decisions?
That's again a good point. So because of the strong evidence that we have now is for proposing the treatment, the primary in low volume disease. So it means that based on the chart criteria and conventional imaging, all the patients that have less than 5 bone lesions can be considered, and no visceral metastatic disease can be considered for a treatment to the primary. It becomes a little bit more challenging when you have this discordance between PSMA PET-CT and PET-CT. But of course, especially if you wanted to consider new strategies like implementation of metastatic-directed therapy in your treatment, like explore now in some ongoing trial like STAMPEDE-2, for example, probably you need to trust on next generation imaging, in this case PSMA PET-CT, and include the true oligometastatic patients. So it's a patient that have up to 5 lesions outside the pelvic and the pelvic region. That could be the patient that probably could benefit from at maximum from the local treatment and probably also from metastatic-directed therapies.
And so how would you approach a man, for example, who is low volume on conventional imaging, and then you have, additional spots in lungs or in liver, and would you still go for...
So no, in this case, because we consider that the patient has some visceral metastasis, so we don't have any evidence to add the local treatment in these cases.
I would say, these men, we are thinking about men who are low volume on conventional imaging, but then you see additional spots, like for example, in lungs on PSMA PET.
I'm trusting more in PSMA PET-CT in these cases, and I'm more inclined to not recommend in these cases the local treatment, the primary, even if based on the PEACE-1 data, we have some benefit to have the local treatment to the primary, even in the high volume setting. The benefit is not in overall survival as observed in STAMPEDE or HORAD, but just to take in consideration that STAMPEDE and HORAD included just patients with the ADT with or without docetaxel. No RP were included in this trial. So probably when you intensify the treatment, you are losing the OS benefit that you can expect by the local treatment, even if the stopgap meta-analysis with data recently presented at ESMO 25 suggested that overall, for low volume disease, you can expect around 5% overall survival improvement at 5 years by treating the primary.
And how do you see the role of radiation therapy in metastatic prostate cancer, in the evolving landscape of systemic therapy? Because, with the PIS1, when the novel combination therapy was added, it seemed to me, but that actually, the benefit of radiation was lower than in the previous studies. And my perspective and my understanding is that the better systemic therapy will have the role of local therapy may be more towards, local progressions and true survival benefit, but it's only my view. I would really love to.
I think so. With modern therapy, when you're combining doublet or even triplet, like Explore, for example, in PIS1, you're probably losing this OS benefit from the local treatment. Nevertheless, you have other clinical endpoints in which you have an improvement. So the radiographic PFS, you can prevent some progression, local progression, and events, GU events. And the other endpoint that you can consider as an advantage is that you can prolong the CRPC-free survival. And I think even if there's no strong endpoint like OS, I think it could be clinically meaningful as an endpoint because in a time in which the intensification from this beginning for the de novo, especially high volume disease, in which we are using triplet, poses some challenges in deciding the fourth step for the therapy. So prolonging this interval could be something that is interesting to achieve because finally it could have also implication in quality of life and prolonging the duration of efficacy of the systemic therapy. The question is how to identify really the true patient that can benefit with high volume disease. And for that, we don't have really the good answer because all the trials implemented from the scratch, the use of ADT, for example, after treatment, just after the docetaxel. Now the question that we can have is we can consider after 2 years, for example, just for the bad PSA responders, if this patient can have a benefit to add a local therapy or not. We can also consider to implement, in this case, a PSMA PET-CT to detect if you have some residual uptake independently from the PSA that you achieve in some spots and trying to treat at these spots to prolong the CRPC-free survival. So I think it's an evolving landscape with many open questions.
So would you consider, you start systemic therapy, there is not perfect PSA response, and then add radiation therapy? Would you be for such approach?
I think it's a challenging approach. So I had some cases in which I was asked to consider for high volume disease to reconsider after 2 years of systemic therapy the local treatment of the primary. And we decided to redo a PSMA PET-CT. So the patient was in response under active treatments. And finally, we observed that there was some uptake on the prostate gland. So we can have this rationale, and finally, probably the PSMA PET-CT can detect before the true CRPC setting that there is something that is developing in the prostate gland. So that's an investigational point, but of course, it's just a hypothesis generating at this time. Yeah.
And how about metastasis-directed therapy? Because, as local therapy is standard, I would say, metastasis-directed therapy formally is not.
So again, it's an appealing field to investigate, but we don't have strong data at this time. So we are running trials. We have the STAMPEDE-2, for example. We had the Oligopresto that, if I'm not wrong, completed the accrual in France, really exploring standard of care treatment, including also the treatment of the primary versus the same plus an MDT to all disease spots for all metastatic patients only, of course. I think it's hypothesis generating, but we need to have a validation before to implement in a routine practice this kind of treatment because we don't have any evidence of the added value and the OS benefit that we can achieve.
In your clinical practice, what is your approach to radiation therapy? What dose do you use, fraction, how you treat it usually?
So in the 3 trials, we had the different fractionation. So for example, in STAMPEDE, we had an extreme hypofractionated schedule, 36 gray and 6 gray per week, or a moderate hypofractionated schedule. PIS1 and HORAD explore more standard fractionation. So we validated almost all type of fractionation. Personally, what I'm recommending, if the patient is fit, if he has no urinary problems, I'm more inclined to use an SBRT treatment, so an extreme hypofractionated therapy in 5 fractions. Eventually, if we have some baseline symptoms for the GU domains, I'm more recommending 20 fractions. Now, in the new treatment, we are more inclined to use more ablative doses like we are using in the standard practice for the curative intent, because in this trial, probably the dose was lower than what we can achieve nowadays with modern techniques. But I think the trend also implemented in this STEMP2, for example, is to deliver full dose radiotherapy with SBRT or moderate hypofractionated schedules.
From my perspective, I feel that when men live longer and longer with metastatic prostate cancer, the toxicity is very also important. The OS benefit, I think, is less uncertain. We have to think about toxicity. And do you think that, I am urologist, so I need to ask it, do you feel that radical prostatectomy will have a role in metastatic prostate cancer? Or from your perspective, the evidence that you know and how you treat those men?
I think at this time, we don't have the strong evidence for recommending radical prostatectomy in this kind of patients. We have some trials. The last one was just published a few months ago. So 1 month ago, I think, the RAMP trial, suggesting that for oligometastatic patients, you can propose a radical prostatectomy. Of course, it's a single center. It's just cancer-specific survival. It's not OS. So I don't think we have the strong data to recommend for this patient radical prostatectomy. But of course, I think key is the multidisciplinary discussion. There are certainly some patients that have some urinary problems or troubles that probably could benefit from also local treatment instead of radiotherapy. But just to be discussed, this is certainly not standard of care at this time.
Thank you very much. And last question, I would like to ask you, how do you see future directions? Because is it do you feel it will be possible to avoid ADT or hormonal therapy with, for example, local therapy, metastatic therapy, and maybe some other systemic therapy, like, I don't know, lutetium, or how do you feel it? Like, how do you see the future of treatment of, I would say, oligometastatic or low volume prostate cancer in the next 5 to 10 years?
I think it's a real good question. So we are starting to have for metacronous oligometastatic settings some trials trying to avoid the use of systemic therapies, in this case ADT. And we have, for example, the LUNAR trial that has been recently presented. So patient with oligometastatic oligorecurrent disease randomized to receive SBRT with or without 2 cycles of lutetium, PSMA. The trial was positive with the benefit on PFS. But overall, if you consider the hazard ratio, is almost similar to the 6 months of ADT from Radiosa trial. So I think it's certainly hypothesis generating, so you can avoid some side effects of ADT. Of course, the costs are much higher. So we need to consider the impact on the healthcare system that we can achieve during or implementing this type of treatment. But of course, it remains investigational and a topic that should be certainly considered in the future.
Yeah, so from my perspective, I think at some point probably we should start moving from ADT in all oligometastatic prostate cancer, especially on PSMA sound, these men probably have very good prognosis. But I would like to stop. I'm very thankful for your interview. It was a great pleasure to talk to you, and I think your remarks and your comments and your view on this field is really insightful. Thank you very much, Professor.
Thank you again for the invitation and great pleasure.
Thank you very much.
Thank you for listening to this episode of EAU Podcast. To keep up to date with prostate cancer developments, visit our educational platform, UROONCO Prostate Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.